So this session is all about retention and how do we retain the staff that we've got. We've got an excellent panel who are going to join me on stage now, if I could ask them to come up. So first of all, we have Ruth May, Executive Director of Nursing at NHS Improvement. We've then got Anne-Marie Riley from Nottingham University Hospitals Trust, and finally Dean Royles there from Leeds Teaching Hospitals. And they're all going to give us their perspectives and talk to us about this important issue. Ruth, I think you're going to kick us off, if I can ask you to do that. Thank you.
Thank you very much, Sean, and good morning still. Hello, I'm Ruth, and it's a delight to be here. I seem to be here at most of these events that Sean invites me to. I didn't come a couple of years ago. It was my daughter's sports day, and I was never forgiven for missing it. So anyway, it's good to be here. I'm talking about retention. So we've got a nursing vacancy drive. We've got nursing vacancies right now, registered nursing vacancies, as well as other healthcare professionals across England of around 36 to 39,000. We've been collecting that level of vacancy data now for over a year, so we're able to measure it on a geographical basis as well as professional basis, which gives us the information to make the policy decisions we need to make. We've recognised we've got that, so we've launched back in June 2017 a programme across England and trusts to support them around retaining nurses and midwives. Mark Radford, who you've heard speak a moment ago, and I lead this project, and we're very proud of the work that you and us are doing to support colleagues being retained. Now, there's two pieces. There's the red line up here and there's the blue line here. The red line is those people that, what we call as churn, those people that move from one organisation to another. And whilst it's good to have some churn, I believe healthily that it's good to go and get experience from one place to another place. Actually, it's the blue line that concerns us most, where we've seen an increase year on year of registered nurses and on the left-hand side, our clinical staff of increase. And that's the reason we're doing this. Now we've got the data, now we're collecting the information, we can really see where we need to concentrate our work. So we need to retain our registered nursing staff. Of course, there is a variation. You can see it's not just a London issue. You can see in the north we've got higher levels of people being retained. But if you look across the whole of individual trusts, one trust in London versus another trust in London, one trust in the south versus another trust in the south, there is a variation. And what we're wanting to do is understand that variation, reduce that variation, and retain our staff as much as we can. So, using the data, this is these bits on the bottom, these bar charts on the bottom, gives us the data from ESR as the reason people are leaving. If there's one message you take away from here today, please, please look at that unknown box in your organisation. We are making policy decisions based on this information, so please, when you go back to your organisations, look about what you can do to support those people that are leaving your organisation, answer the questions and making sure that we input the information through your HR teams into the ESR systems along the reasons. I'd quite like to work out how we take that unknown box away, but please, the reason people are leaving is important to understand. But there are factors within the trust control. There's factors within all of our controls. And I'd like to share with you in a moment some case studies of where people have started to work on this already. You've already got two people that are following me that is doing this work, exemplary work, in Leeds and in Nottingham. And I'll leave them to tell their story. But I'll go on to share with you with two organisations that are doing this right now. But the National Workforce Retention Programme has two main parts to it. A universal offer that's offered out to every member, every trust across England. And then the masterclass, and then the real support that we need to give to a range of trusts within that we're working with. We're working with all mental health trusts, so we've done 3 cohorts now. Cohort 3 is still working with us, but we've done 3 cohorts, identifying, we're giving the data to trust, looking at the data, slicing it and dicing it in all sorts of ways to help them to refocus on where they need to concentrate, whether it's a particular staff group, whether it's a particular age group of registered nurses and staff. We're then working with about a third of community and acute trust this year, and by October this year we'll have the offer out to work with all trusts across England. We've come to learn from the Cohort 1 about the key drivers, and those are in the dark blue data, the dark blue blobs up there. Understanding the data I've talked about is really key. The pre and post retirement, how do we capture those over 50s, those people like myself, about how they're planning to work, what are they wanting to do in their coming up to retirement? How can we make sure that we support them to think where past 55 they can continue to add value? And there's lots of trust. BHRUT in Havering, Romford area. Catherine's doing some amazing work there about capturing people early and making sure that we can support them going on into their new second and third careers. The new starters, the newly qualified, and we've split those out on purpose. The newly qualified, we want to keep people, our newbies, but it's not just those people that new qualified, it's those people new into an organisation. And trust making focused discussions, focused debates, focused support around those people are really important. There's a lot of detail on this slide, and they'll be available to you later, but it's those areas that we've talked about are the ones that are coming up as the main lessons learnt for our first cohort. So, Tameside and Glossop, amazing work they've done in the first 12 months. Look what they've done to reduce turnover for our Band 5s. Superb. They've done lots of little pieces of work. They speak at lots of conferences. But what they've done is to focus the conversations, to provide dedicated conversations with frontline staff and making sure that as a whole board, from the ward to board, from board to ward, there is a real focus on retaining staff. Look at what RDash have done too. They've done lots of itchy feet clinics. There's many examples on our website and that Mark and his colleagues have been developing and been collecting. Best practice examples that you are in this room and colleagues back at the ranch have been giving us. It's there to share with you the types of things we're doing. Alongside that, and newly launched, is around the work we're doing around health and well-being. Much has been done about this, you know, Carol Black, Stevenson and Farmer reports. Many reports have been done, many reports have been said, many bits and pieces of paper have been on shelves about what we need to be doing about well-being. Well, it's absolutely key to retention. We've started now through our Cohort 1 to work out, I don't know what checkbox with arrow, left and text, I don't know what that means, I apologise, I'll go back. One of the things we've really understood is through our Cohort 1 and 2 is that there's an absolute link between retention and board's focus on well-being of staff. So what we are now doing is joining the cohort through retention with the Cohort 1 of the work we're doing on health and well-being so that we can drive forward our support for the health and well-being of our staff into making sure that we retain. I'll try this one more time to see if it works. It doesn't. My apologies. I shall go on. We are working with 73 trusts across the whole of England. We're working with 10 of the ambulance trusts that's starting this month. We're working with a number of trusts to work, helping them with the direct access into multiple MSK, as well as mental health services. So we're doing a fair amount of work about how we support you. It's very early days in what we're doing with the mental health, with the well-being agenda, but tying it up with the retention work is crucial to us. So for us, over the next 6 months, is how we get to see the results of Cohort 1 and 2 with our retention work, how we continue to support, how we continue to share the best practice that you are developing, and how we tie it up with the health and well-being agenda. So those are the policy decisions, the policy priorities that we're making between now and the end of this financial year. I'll hand over now to our colleagues.
Hello everyone, my name's Dean Royles. I'm the Director of Human Resources and Organisation Development at Leeds Teaching Hospitals. Thanks to the HSJ for inviting me to come and speak at this event. I just wanted to talk about what an NHS Trust is doing to look at issues around recruitment and retention. So a little bit about Leeds Teaching Hospitals. Leeds, one of the largest trusts in the country. We've got around about 18,000 staff. We see about 1 million patients, turnover a little over £1 billion a year. And as every true Yorkshireman has to say when they're on this side of the Pennines, is Leeds is also in the most beautiful county in the country, in Yorkshire. So if you don't know about it, come across and come and have a look at the things that we've been doing. I guess a little bit of background before I talk about what we've been doing. But for a number of years, I think that Leeds was an underachieving organisation. So as a large teaching organisation, it wasn't one of those organisations that people talked about when they talked about teaching hospitals doing good stuff. Like many organisations, we've had problems with recruitment and retention, mostly because there aren't necessarily the people there to recruit. But in addition to that, from a HR perspective, some of our processes were slow and cumbersome that were supporting that. So we were losing people before we'd even got them into the organisation. We were CQC requires improvement. We've got a large deficit. Some of you will recall the Savile inquiry that took place that was centred in Leeds. There'd been a high turnover of a senior team and a sort of sense of an organisation in constant turnaround. And as I say, just a sense really that we were punching beneath our weight in areas like research and profile, given the size of the organisation. And all that was underpinned by poor staff survey results. So the things that we've tried to do is really just to have a look about how we can improve the culture within the organisation, and we've tried to embed something we call the Leeds Way. So that's a clear set of values that we want everyone in the organisation to understand and subscribe to. So a clear vision and clear values in the organisation. And then we've built our staff engagement model around that. So all parts as people come into the organisation. So whether you're looking at how people arrive in the organisation, their health and well-being when they're in the organisation, how we engage with staff in terms of two-way communication, how we recognise and celebrate the achievements of staff. And I should point out that one of the things that we don't do really when we're talking to staff is talk about staff engagement. To me, it's a sort of managerialist term, and we need our managers to understand what it is that we're trying to do to build that level of staff engagement. But for staff, really, we just want Leeds Teaching Hospitals to feel like a community that they belong to. You know, does this feel like a place where you've got belonging? That's what we're trying to achieve through staff engagement. So really important that we look at all aspects, I think, of that wheel when we're looking at improving staff engagement. But I just want to touch on one or two things just to highlight some of the things we do. So if I look at that effective communication, we've done quite a lot around crowdsourcing of our staff. So I think often when people talk about communicating with staff, people are talking about broadcasting to staff. We very much see communication with staff as listening to them. So we use crowdsourcing technology, we meet with them regularly, we get regular feedback through surveys of what they think of the organisation, and we try and act on that feedback and show them what we're doing in relation to that. If I look at the bit about the employee journey, there are some disadvantages of being a large organisation, but you get some great advantages too. So because of the size of the organisation, we're able to have an induction day every week. So every Monday we have our induction, and every Monday we have somewhere between 50 to 100 new starters join us. And that means we can get a sort of drumbeat into the organisation about how we welcome those people into the organisation. Every Monday we also have our executive team meeting, and every Monday at the end of that first day induction session, we invite anyone that's got a leadership role in the organisation to come and meet the executive team, and we just have 5 or 10 minutes with them to re-emphasise the things that they would have heard during the day in respect of the Leeds Way and how we think that's important to retaining our staff in the organisation. We want people to stay in the organisation because they feel valued. But we also ask those leaders to hold us to account as an executive team for leading the organisation in that way. And we find it's easier for them to come back to tell us if they don't think we are because they've met us on that first day of employment. So some of those things are really important to the things that we do. Say all aspects of that important, and you can sort of see on the wheel there the different work that we are doing. And here's some of the sort of impact, really. So if you look back to 2012 in terms of the staff survey, you can see that of the 30 indicators, we had 18 that were in the lowest 20% in the country, and none that were in the top 20% in the country. And we've improved on that sort of year on year, so that in the last staff survey, we had one indicator that was in the bottom 20% of the country, and we now have 13 indicators that are in the top 20% of the country. And that journey, I think I put that slide on to tell you one or two things really. I think sort of engaging staff so they feel part of the organisation isn't a quick win. You've got to spend sort of time and effort doing it, but you can see results over time. And secondly, I think you can see the progress that we've made or how far we had to come, because I think for 2 of those years, we were the most improved trust in the country 2 years running in terms of staff survey results. But we're really pleased with the way that staff feel as though they understand now aspects about the Leeds way, the values in the organisation, and what we're trying to do to make it one of the best places to work in the NHS. If you just have a look at some of the improvements in terms of recruitment and retention, so you can see our headcount has gone from, in April 2013, we were about 15,000 staff headcount. We're now sitting just around 18,000 staff in headcount, and we've seen a similar plotted line as well in terms of whole-time equivalent members of staff. And then likewise in terms of turnover, just a note of caution here, this is a different scale on the side to the one that Ruth was showing, but you can see that there's been a reduction in turnover when lots of other places have got turnover going up. So for me, some of the key points, as it were, so really important, I think, in an organisation, that the organisation has a clear purpose and vision, and that you're listening to staff when you're communicating that vision to them. I think there's something about intentionality. So you can look at, as we did back in 2012, look at areas like the staff survey and think, where do you start on something like that? But there are areas of the staff survey, there are areas of an organisation that you can go about and you can intentionally seek to improve. So you can intentionally go about seeking to improve how staff feel about whether you look after their health and well-being. You can go out and you can improve the rates in which you do appraisal, for example. You can go out into the organisation and you can help staff to understand what they can do to make improvements at work where they feel supported. So all of those areas you can go about setting about a course of action to improve those on. And all those areas, I think, help to the sense of belonging that people have got within the organisation. And then finally, this really important thing about embedding an improvement methodology. So we want Leeds Teaching Hospitals to be one of the best places to work. We want to recruit people into the organisation. But we don't only want people to do the work well, we want them to improve each day the way that that work is done, to look at where we've got waste in the organisation, try and remove that waste so we can improve patient care. And we've been trying to equip staff with the tools to be able to do that. So that would be my 3 key takeover points. Thank you very much. And again, I shall hand over to my fellow panellists. Thank you.
So my name's Anne-Marie Riley. I'm Deputy Chief Nurse at Nottingham University Hospital. A little bit about Air Trust. So again, we're a big organisation. We've got about 1,700 beds, 15,500 staff. We cover a population of about 2.5 million with our general services, 3 to 4 million with specialist services. So we're a big old organisation. We've got about 4,500 registered nurses and midwives and about 1,500-ish care support workers in various guises. And it's a little bit about what we've done at Nottingham to try and improve recruitment and retention. This is predominantly nursing, but the principles apply across all members of the MDT, and we are increasingly working with a medical team and AHPs to see how we can drive some of the improvements that we're starting to see in nursing across all professions. So what we've been on is a journey following magnet principles, and if you haven't heard of it, it's the highest designation that you can get in terms of your quality, your outcomes, and in terms of the quality of care that's delivered in your organisation. It's a really strict framework. They monitor outcomes and experience of your staff. So it's not just what we provide as a senior team. They want to know that those closest to care delivery, which are your Band 5 nurses, absolutely live, breathe, understand their place, their contribution, and what they add to strategic vision. So what is it? So America in the 80s had a similar issue that we've got now in terms of retention and recruitment, and the American Academy of Nurses set up a task force to look at organisations that didn't have the same issues in terms of retention and recruitment, and they looked across 163 organisations and found that 41 had key areas where it was really common in terms of when they had these in place, actually their outcomes were better, their nurses were happier, and they didn't have the same recruitment and retention issues. So there's 13 principles. They called it the Forces of Magnetism, which is really American, and it's the term they used, and obviously it's about what attracts people to your organisation, and that's probably what the basis of that is. And they fit under 5 domains. Which you can see, and we can provide more information if you want anything on any of the magnet information. But they're really key that it's about your leadership, it's about how you set up your systems and processes, and how you involve your registered nurses in your vision of your organisation, and that you value their contribution. So in America, obviously, it's a profit-based healthcare system. Magnet journey is quite expensive to go through, so we were really key to, for us to understand what would promote an organisation in America to go through this process. And they were really clear, the people that we've talked to, so they absolutely have better outcomes, they absolutely don't have issues with recruitment retention. They understand that if you keep the right nurses, give them the right training, and they stay with you, actually your costs reduce because you're not spending on turnover, and your outcomes are better. And litigation, obviously, if your outcomes are better, your litigation cost might be lower. So certainly from an American perspective, this is seen as a very cost-effective way to run your organisation, and that's why, given the cost, people are still going through it. So why did we decide to go through it? The journey started at NUH a while ago, and I'll talk through that. But it was seen as a way to try and bridge this gap that we've got in terms of trying to retain nurses. We know that the people leaving the register aren't the ones predominantly that are retiring. It's your 30 to 40-year-olds, and we know that people expect something very different from the career than when we started. And this is seen as to be a way to help us bridge that gap. So the journey started in 2010, where a member of staff went to America, learned about shared governance, brought it back to Nottingham, and the chief nurse at the time was incredibly visionary, and it put all the principles in terms of magnet into place. So shared governance was trialled in small areas, but has grown quite a lot, and I'll talk a bit more about that as I go along. They absolutely focused on education and clinical academic careers, which again at the time was quite visionary when other people probably weren't doing that. We've been looking at our outcomes and comparing that to peers. So part of the magnet process is you benchmark against peers, and you have to outperform the top quartile. So we've been looking at our information, realising that we were able to benchmark quite high. And then in 2016 decided that we would formally go through the process of achieving magnet status. Took a paper to the board, and we were very lucky that our charity funded the journey. It's really quite expensive to go through it, and we couldn't have done it without them. We put a Magnet Direct program director in, and we will submit our data next year. So hopefully, fingers crossed, if it all goes to plan, we'll be the first in the UK to achieve that. That's what we're all striving for. In conjunction, as we've started the journey in 2016, we set up an Institute of Nursing Midwifery Care Excellence. So we were really clear on ensuring that we were focused on education, research, and as well as embedding what we call magnet, but will just become how we work in everything that we do. We talked to staff a lot. They were clear that actually when you start your career, it's quite confusing where you go, what you can do, what your options are, what the programs of education are. So we've listened to staff, and then we're trying to put in a process to make sure that we can get it right for them. They weren't sure in terms of what some of the specialist roles were, so clinical academic careers, some of the nurse specialist roles. So what we're doing is demystifying that, making sure we've got clear programmes, that they're sure what their routes are, and we can support them through that journey, because we want them to stay with us. So it's in our benefit to make sure that we've got these routes right. So in terms of ensuring that we get staff to stay and we develop them the right way, we talent manage, and we are trying to make sure that as we spot talent, we can develop people and give them the support they need to, one, stay clinical, two, lead and improve and be involved in everything that they're looking to achieve throughout their career. And it starts at Band 5, and we need to do that through a whole range of somebody's career. The shared governance councils, we've got about 55 councils now. So these are teams at ward level. It's led by a Band 5, or it can be anybody actually, but quite often it is Band 5. They get a programme of support, and we've got a fantastic team that make sure that they've got their skills to be able to lead a unit programme. They lead a range of work. There's a leadership council, so all the leads from these practice councils come and meet with the chief nurse. I chaired a meeting probably 2 weeks ago, and there was 53 projects being discussed. We didn't have every council there. So despite an incredibly difficult winter, there's 53 different projects being led right at the level of where the patients are. We make sure we look after our newly qualified. We also look after our students, because they're our next generation of nurses. And we make sure that we've got our education programmes in place. This is just a reiteration of what I've said. We make that what it's making us do is rethink some in terms of how we plan education programmes. We know that certainly for generations of nurses, they want their education, they want to be developed, and yet when we're under pressure, that's quite often the very first thing that goes, and we've got to be able to plan better so that isn't the case. We're not going to encourage people to stay and give them the impression that we value them if the one thing that they mean something that we take away when we're under pressure. So we're having to rethink what we do. And we're really proud of what happens in nursing at NUH. So we're proud around the innovations that they lead. We're proud of the technology that we use to try and make their jobs easier. So we're constantly looking to see have people got the right tools. We're looking at all of our clinical staff have handheld devices. So where we can, we make everything electronic. We make sure the data is available in a couple of clicks, because we want them to be focused on being able to deliver care, but use the information that's widely available, but get it easily, because what we want them to do is focus on outcomes, not about data collection. Wherever we can, we're trying to take out those manual processes. So I think that, in a nutshell, ties up what we've done. It's really quick. There's been lots that's been done. And is it working? It seems to be. So there's really green shoots that this is all staff for the nursing screen is very similar. So as peers were struggling, we seem to be on this upward trend. The month after that drops a little bit, but we know it goes back up again afterwards. So there's green shoots that this approach does work, and it certainly fits into what the evidence says in America. So again, we'll hopefully, if there's any questions, you can ask me in a second, but that's my talk.
Thank you, Anne-Marie, and thank you, all three of you, for an excellent run-through of these issues. So let's get the elephant out of the room first. Isn't this the issue of retention that we've seen, this growth in people leaving, isn't it just down to the fact that we've had pay restraint for 7 years in the NHS, and people are sick and tired of that?
I'm very happy to go first. I genuinely believe, it's a personal belief of mine, I've been on many a platform and said this, I do believe pay restraint has been one element that has driven this, and it's had a negative impact on retention. I'm pleased to see the governmental response to this, and seeing that the unions and colleges have accepted the pay offer. So I do believe pay is one element. It's not the only element. We've seen other areas, there's other evidence where the causes to the vacancy rates we've got now, but I agree, pay has been an element.
I would agree. I think pay's been an element in two respects. One, there's the absolute value of pay, But I think probably over the last 3 or 4 years, a sense that not getting a pay increase is a lack of value. So irrespective of the monetary value of that, it said something about the value that we put on staff. But also, I think a big aspect of it is it's hard work. I sit in an office probably as far away as you get from sort of patient care, and I get some sort of exposure to that. But whenever I go on the awards, whenever I go around clinical areas, whenever I walk around the organisation, people are working really hard, long hours in demanding jobs and roles. So there's other aspects, I think, about how we can look after them, support them, make them feel valued at work, try and invest in their training development. There are also aspects about that as well.
Anne-Marie, on the issue of pay, you're talking, and you are trying at NUH to do a lot more on education, training, valuing the profession, etc. But how often is pay cited to you as a reason why I'm leaving the trust?
It hasn't. I'm sure it is a factor, but it hasn't. People generally will move on because they're not getting fulfilled in their role, whatever that means. So whether that's they're not getting the education and training that they need, whether they don't seem to have a voice in the organisation, there would be more likely the reasons that we would hear that people are going, which is why there's such a focus and we believe this approach will work. So one thing that we're about to do is Band 5s will sit on a nursing and midwifery board from this month. They will be involved every strategic decision, and we've got to start changing how we work to value, what people who are facing the patient every day are facing, and we need to listen to that. Yeah,
there's a question that's come in on Slido from Sally about, but not from Sally, from AM, which says, I don't see an explicit comment about the IHI joy in work. Does the panel use that phrase? If not, why not? I mean, that is a key point, isn't it? With staff aren't enjoying their job like perhaps they once did. The pressure on staff is immense now. And even though we've got more of them than ever before, the workforce data shows that, but they're not feeling that, are they, on the ward because of the demand on them? So how can we give them joy in their job?
The IHA framework about the sort of joy at work, I guess people express it in different ways. And we try and say we want Leeds to be one of the best places to work. And to do that, we've got to create the right environment for people to work where they feel valued at work. They know we're going to invest in their training and development, whatever role that they do. They know that we'll help them look after their own health and well-being. So whether that sort of leads to joy at the end of that. But in addition to that, hard work, I also know that for all of us, whatever role you're doing in the health service, it is incredibly satisfying, because you do change people's lives, whether that's vicariously through working in a back office function, supporting staff, serving them to serve patients, or the direct care that we get. We've all been doing NHS 70 celebrations recently, and emotional stories about how people have gone over and above that extra mile, how proud people are of the job of work that they do. I guess to some extent you could describe some of that as joy in terms of what they do.
Yeah. I certainly experienced a fair amount of joy last week when I was part of, like many people here, were part of the NHS 70 celebrations. I was in Midlands and East event in Nottingham, and just listening to Band 5, Band 6, Band 7 staff tell their own personal stories about their joy, about why they come to work, the impact that patients and their families have had on them. It is a tough job, but it's also an amazingly rewarding job. And I had a lot of joy last week and a lot of inspiration from frontline staff celebrating NHS 70. And indeed, we've seen that as well through some of the adverts recently with the recruitment campaign that was launched last week, some of the experiences of places in this city from the attacks as well, where the people that have experienced their response to the attack, some amazing individuals doing some amazing stuff.
Ruth, can I ask you, I know you and I have spoken about this before, but all of this work that is being done, this recognition now that we need to tackle this issue, kind of feels to me like we're 5 years too late. Why weren't we on this immediately before Francis published and before we started to see this problem increase? Why wasn't the NHS, as one of the biggest employers in the world, professional about this and know these things before? Why has it taken a crisis to get us to act?
I don't know. And perhaps that's some of the part of the cultural stuff that we probably need to learn from. What I do know is that, you know, the NQB work that I was on a platform, developed it, the NQB, the 10 commandments or the 10 commitments is often referred to, where we talked about the journey we've needed to come on, putting safe staffing on the agenda for boards. I remember prior to that, I was supporting directors of nursing, wanting to take those papers, but didn't feel confident enough to take those papers to board. We've seen a big transition. I think the next big transition is that we don't lose the focus on patient safety coming over the next few months and years, but instead we turbocharge what we now need to be doing. I was struck particularly around the slides earlier around what we didn't know and what we said we didn't know around cancer and relating that to safe staffing and the role of the registered nurse. We know we must use the evidence, we must use this agenda now and the political backing we have had for patient safety and for safe staffing to really turbocharge this. I'm personally committed to doing that so that we don't waste any time thinking about what we, if hindsight, we could have done. And I've really enjoyed this morning's sessions, and you've challenged me, and the speakers today have challenged me about what ought to now be the turbocharging of what we need to be doing.
Well, we'll watch closely what happens. But
and you looked at hold me to account as well.
But in terms of the National Workforce Retention Programme that NHSI is leading, I think a lot of people have said, you know, this is good intervention from the national regulator. It's getting involved and helping and supporting people. Are you seeing evidence that that is improving retention in those trusts?
We are so far. So over half of the trusts that we've worked with in Cohort 1, we're seeing a positive impact. We're not seeing it in all of them. Some of them is because they've got a huge challenge, and some of them perhaps we haven't seen enough of the executive focus being put on it. But we are seeing some big improvements. We're only 3 data sets in. I've got a 4th data set coming very shortly, and we'll soon see whether we're seeing it. What we are trying to do is to put the improvement into the NHSI. We are noticing the big difference around whether there's the 3 success factors around that we're saying is there enough leadership right through the organisation? Is there enough engagement with the staff? So this is a joint project. And is there quality improvement methodology? Now, we've seen 2 organisations describe today their quality improvement methodology. It doesn't matter which QI methodology is used as long as there is one and it is being used in depth. So I genuinely believe we're on the cusp of something great around retention, but proof will be in the pudding.
Anne-Marie, I wanted to ask you about this. The work you're doing at your trust, it seems very much around giving staff a sense of purpose, a career, something that they can see on the horizon. And we're all familiar with the argument that if you want to be a senior nurse, you have to go into management and become that kind of person. There isn't a clear career framework to just be a good clinical nurse and develop that way. And obviously that's something you're trying to do. Is that a problem more broader, that we see staff as like units of activity that just deliver work rather than valuing them as people who have career aspirations?
I think it has been historically. I think in terms of pathways, I think it's really sad that you can't be an excellent practitioner and stay close to a patient. You can in medicine. We need to start thinking how we can let people be clinical. You know, what we're trying to do is, at Nottingham, is show the absolute value of the registered nurse and the contribution they make to their patients, their team, and to us as an organisation. And you know, there will be band 5s and band 6s, you know, predominantly, that are very clinically focused. And we have to find ways to keep them nearest to the patient, because that's where they're best placed to impact on the outcomes.
Yeah.
So yeah.
Okay, well, we've run out of time, sadly, but I think that's hopefully giving you guys some thoughts on how you can improve retention and improve the experience of your staff there. But if you can join me now in thanking our panellists for that session. Thank you, guys.